Hello, I'm going to talk about the statistical analysis of randomized trials, and I'm going to discuss a specific issue about this analysis, which is moving this analysis from a single endpoint to a patient-centric benefit risk assessment, so a much more global assessment of the benefits and risks of a treatment. So when we do the statistical analysis of randomized clinical trials, as statisticians, what do? We actually use the so-called conventional statistics that you've all seen. We calculate survival curves, we compare survival curves, we calculate forest plots for subset analyses, we compute hazard ratios, odds ratios, and all kinds of statistics. And if you think of it, these analyses have two problems. The first problem is that we focus on typically a primary outcome measure or a primary endpoint, for example, overall survival and the hazard ratio of overall survival for the comparison of the two treatments. And in fact, the second problem is that not only do we focus on a single endpoint, but we produce statistics that are very hard to understand. A patient typically does not really understand a hazard ratio unless that patient is a statistician. But we prefer to talk about simple statistics of the primary endpoint of the trial because that makes our life easy. Now, if we go to the patient view of a clinical trial, what matters to them? What matters to the patients? Well, patients have several concrete questions, such as how much longer can I live? Or will treatment be painful? Or what will be my symptoms? What is the chance that I will do better on treatment than on control? I mean, the last question here is probably more a question, again, that a statistical patient would ask themselves. But so these questions relate to the benefits of the treatment, the harms of the treatment or the risks of the treatment, and then some kind of an overall assessment of the benefit risk. And typically, we just don't do this as statisticians in clinical trials, working in clinical trials. And that is probably something we should be doing more and more. So I'm going to show you a short video. It's a 4-minute video that will show you how we can actually position a statistical approach of the patient-centric view of randomized clinical trials. And this video is pretty simple. It's not statistical at all. It's aimed at patients or clinicians or non-statisticians. And as you will see, it is fairly easy to understand the approach that this video is advocating. And I will come back after the video to show you some details of the statistical analysis we propose.
Advances in research and new technologies mean that the number of new treatments approved by the authorities has increased tremendously over the past couple of decades. Having a larger choice is nice, but how do we make sure that the best possible treatment is given to a certain patient? When new drugs or treatment methods are proposed, we study them across several phases of clinical trials that help identify the most promising approaches among those considered. Finally, the best of them is compared with a currently accepted standard treatment by administering them in 2 groups of patients. These trials are designed in such a way that this comparison is based on the treatment only, while minimizing the influence of other factors, such as age, gender, or underlying diseases. Typically, the trials focus on a single outcome of the treatment considered most important by the researchers. In practice, however, a patient might be concerned by a different or even several outcomes of the treatment simultaneously. A treatment that gets rid of an infection but is very toxic is not the same as a treatment that fights the infection and is less toxic, right? The method of generalized pairwise comparisons, or GPC, allows to do just that, to evaluate all outcomes of interest at the same time and in a desired order of preference. Consider a trial that was performed to compare appendicitis treatment by antibiotics rather than the usual surgery. We begin by asking ourselves a question. Among the possible outcomes affected by this treatment, what are the most important for us personally as a patient? Then write them down on a list starting from the most important. We then take 1 patient from the antibiotics group and 1 patient from the surgery group and compare their outcome of the highest importance on the list. In our case, the number of days it took our patient to recover. Then we decide if the patient on antibiotics from this pair has recovered faster, or maybe the patient after surgery had faster recovery. Sometimes the decision is not easy to make. Maybe both treatments have taken similar time to work. Then we would look at the next outcome on our priority list and compare its value. Can we decide if antibiotics were doing better or worse than the surgery here? If we can, we leave it at that. If not, we would go and look at which of the two patients had better quality of life 1 month after treatment. All of the patients on antibiotics are compared in this way with every patient from the group undergoing surgery. We can now measure the effect of the antibiotic treatment compared with surgery. This measure is called net treatment benefit. It reflects the difference in the number of times that the treatment with antibiotics was better and the number of times that it was worse than the surgery. A value larger than 0 means that the antibiotic treatment is better. If the net treatment benefit is less than 0, we would choose the surgery. This conclusion is based on the particular preferences that we have chosen. What if someone else had a different order of personal preferences? The net treatment benefit value will then change. It will inform which treatment is preferable based on this new list of personal choices. Without GPC, your treatment decisions are based on general expert consensus on what constitutes a single most important outcome, one which may not necessarily reflect your preference as a patient. GPC is a method that empowers you by allowing to participate in making treatment choices. Now the decisions are truly tailored to your own wishes and needs.
All right, so this video showed you the essence of the methodology that I would like to discuss today, and I'm going to go into some details of what was shown very clearly, much more clearly than I could present it in the video. So what the method consists of is to define thresholds, but before we do this, define priorities. As the video said, each patient has their own set of priorities. They might, for example, on this slide, choose time to death or survival time as their first priority outcome. And then they might say, well, avoidance of pain might be the second outcome. And then having or not having certain symptoms might be the third outcome, or the severity of the outcomes might also be important. And so we can decide on the list of priorities depending on the patient preferences. Now, an analysis would be done using that particular order of preferences. Secondly, the patients, in fact, don't just think as to the order of the outcomes or the priorities of the outcome, but also what kind of difference would be important for them on each of these outcomes. For example, in terms of time to death or survival time, what kind of difference in survival time would be relevant? It's obvious that if the survival of a patient was improved by 2 days, that would be trivial. That wouldn't be worth taking a treatment. But if it was 2 months, or even better, 2 years, then it would become really interesting to take the treatment. Likewise, for pain, the intensity of the pain is as important as having it or not having it, and the same for symptoms and so on. So not only do we list the outcomes in a pre-specified order, but we also define for each outcome a threshold of clinical relevance. And having done that, then we can use a statistical method. You might think, well, this is all becoming very complicated, but we can use this method of generalized pairwise comparisons. And that, in fact, as I will show, makes the analysis so simple that it's just unbelievable. You can do so much with so little, in fact, mathematics. What you do, as it's shown in the video, is to form pairwise comparisons. So you take one patient in the treatment group, one patient in the control group, and you, for example, here denote by Xi the outcome of the patient in the treatment group, and Yj the treatment of the patient in the control group. And in fact, then you decide if that particular pair of patients is a win, if it favors treatment, or a loss, if it favors control. If you look at survival times, for example, if Xi is greater than Yj, in other words, if the patient treated has a longer survival than the patient in the control arm, then that's a win. The patient treated is a win. Otherwise, it's a loss. If the treatment in the control group does better than the patient in the treatment group, that's a loss. And if the two survival times are equal, then obviously you can decide, and that pair is called a tie or an uninformative pair. So that's the pairwise comparison. Now what we do is to do this process on all possible pairwise comparisons. Here I've shown an example of two groups of patients, two groups of 6 patients. So 6 patients treated in blue, 6 patients in the control group in red, and you form all the possible pairwise comparisons. 6 by 6, it's a 36 pairwise comparison problem. So you have 36 pairwise comparisons. For each of the pair, you decide if that pair is a win or a loss or a tie. And then the calculation of the net treatment benefit is fairly easy. You just do the calculation of the number of wins. You do the calculation of the number of losses, and you know how many pairs you've got. You just do the subtraction of number of wins minus number of losses, divide by the number of pairs, and that's your net benefit. So that's, in a sense, the expression of the overall benefit for all outcomes considered if you have several outcomes. And it shows how many patients are actually doing better on treatment than control. It's the probability that a patient taken at random would do better on treatment than control. If the net benefit is 0, that means there is no benefit. There is no difference between treatment and control. If the net benefit is 100%, that means all patients do better on treatment than control. And if the net benefit is minus 100%, obviously that's an undesirable situation. That means the control group would uniformly do worse than the treatment group. Of course, that would not be a situation that we would want to be in. Now, in practice, of course, the net benefit is never plus or minus 100%. It's, something around 0, but sometimes it diverges from 0 if the treatment has an effect in a way that is interesting, both statistically and clinically. Now, what makes this method particularly attractive is this business of the threshold of clinical relevance. When you compare the outcome of the first patient with the outcome of the second patient, you can decide that the pair is a tie for if the difference in that pair is less than the threshold of clinical relevance. So, for example, for survival analysis, you could say, well, if the difference between the 2 survival times is less than 3 months, let's say, then I would consider that that difference is really not clinically important. If the difference is more than 3 months, then of course it becomes important. And I can do the analysis with different thresholds just to see what kind of threshold would make the treatment significantly better than the control. And the other extension that's very important is that we can do this for multiple outcomes. If we have multiple outcomes, as I said, we can order them by descending order of priority. And then we look at the first outcome. If that first outcome allows us to classify the pair as a win or a loss, we're done. If not, so in other words, if we don't have information in the first pair, the first outcome makes this an uninformative pair or a tie, then we have to go to the second outcome. And the second outcome might then help us to classify the pair as a win or a loss. And then if we have more than 2 outcomes, we continue this process until we've exhausted all the outcomes. And at the end of the day, we may remain with a few uninformative pairs, obviously, but all the other pairs will help us to decide which of these 2 treatment arms, the control or the treatment, is in fact better. So the method is conceptually extremely simple. Mathematically, it is also extremely simple. The characteristics and properties of this method have been studied in great detail, and the advantages of this method are, in fact, many. The first advantage is that this is a completely non-parametric approach. It doesn't require any assumptions. You often hear about assumptions we have to make statistically, such as the survival distribution has to be exponential, the hazard rates have to be proportional, or the distribution of the outcome must be normal or something like that. We don't need any of this here. It's completely non-parametric. We can use this method for multiple outcomes, providing we can order the outcomes by descending priority. And the outcomes, of course, can be efficacy outcomes or safety outcomes or any other outcomes. Could be quality of life, could be even biomarkers if we wanted. So we can really throw in this methodology any outcome that we can measure in a patient. The GPC also permits a mathematically rigorous benefit risk analysis that takes into account the correlation between the outcomes. The benefit risk analyses that you see performed do not, in general, take the correlation between the outcomes into account. And that's a huge problem, because think of a treatment that's very toxic but helps a few patients. That's a very different situation than a treatment that is very toxic in the patients who benefit from it, rather than in the patients who do not benefit from the treatment. You would want to use a treatment that's toxic, providing it would help the subset of patients who also have toxicity. But you wouldn't want to use this treatment if it induced toxicity without helping the patients who have the toxicity. So that correlation between the outcomes is extremely important to do a correct benefit risk analysis. The net benefit is a universal measure of the treatment effect that has a straightforward probabilistic interpretation. It's the probability that a patient will do better if treatment than if on control. So it's a very simple probabilistic interpretation of the net benefit, regardless of the outcome or number of outcomes you look at. It's always the same interpretation. And last but not least, coming back to the title of my presentation, this is intrinsically patient-centric because the order of priorities can be adapted to each patient, and the thresholds of clinical relevance can be adapted to each patient as well. So let me mention a few applications of GPC that we've been working on recently. Of course, we've used this feature of thresholds of clinical relevance, for example, to say, well, is the survival on treatment better by at least 6 months compared with the survival on control, or at least 12 months, or at least any number of months? So we can vary the number of months and look at the net treatment benefit as a function of the threshold that we choose. We can also look with GPC at non-standard situations. One issue that has bothered clinicians recently is the fact that immunotherapy in oncology produces a treatment benefit, but which is delayed. So you have to begin treating the patients and expect to see a treatment effect later, sometimes much later, sometimes several months later. And this is because of the mode of action of immunotherapy. It takes time to be activated, in a sense. So the standard methods of statistical analysis, in particular the log rank test, the Cox model, and all these methods that we use in these situations are just not appropriate because they don't account for the fact that the treatment effect is delayed. So in that case, GPC can be a much better option. We can say, well, I want to have a survival time of at least so many months, and that will in fact compensate for the fact that the treatment benefit gets delayed in time. Another situation that I think is quite important is when you have two events that are time related, for example, progression of disease and death. Typically what we do is the time to first event, so time to progressive disease or death, whichever comes first. The problem with this analysis is that if the patients progress, we ignore the time after progression until death. And of course, that's really putting things upside down, because what we would really like to do is to look at time to death. And for patients who haven't died yet, for those patients, we look at time to progression. That would make much more sense clinically and also for the patient. So that's another cool application of GPC. Mixed outcomes, like I said, sometimes we can analyze outcomes that are not the typical as traditional times to event or binary outcomes such as proportions of events, but we look at things like circulating tumor DNA. We can easily add circulating tumor DNA levels in a GPC analysis. The type of event that you look at can be any, and that's really very powerful. Another application is multidimensional scales for quality of life, for example, where you have multiple dimensions that are measured. GPC can be used, again, to get an overall assessment of the quality of life on multiple scales, which is not easily done with any other method. And this can be pushed to the limit, and there are a few researchers who work in that direction, using very highly multidimensional data, such as gene expression profiles, which you can also analyze with GPC. So it's a very kind of promising method, and I'd like to finish with looking at who might be interested by GPC. And, you know, again, if I come back to the title of my talk, I believe that it's the patients who might benefit most from a GPC type of analysis. And I've indicated here by a circle plus something that's really important. A threshold of clinical relevance is really important for the patient. And mixed outcomes, benefit and risk, is very important to the patients. And I've listed a few other users of GPC, potential users: clinicians, regulatory agencies, health technology agencies, or health technology assessment groups, the pharma market access group in the big pharma industry, and the pharma R&D departments for the regulatory approval. So if we kind of group these different users together, we have the consumers, in other words, the people whom we want to target GPC at, We have the regulators, of course, who have to review a new drug application and approve a new drug or not. And then we have the payers or the producers, typically the pharma industry that produces new drugs and that want these new drugs to be used and approved. So I think GPC actually can be useful for all of these groups for different reasons and for different types of applications. But again, if you look at the patient column here, it's obvious that the GPC approach provides patients with a much better and much more exhaustive view of the benefit risk of a treatment, rather than having to rely on separate analyses of each of the endpoints using statistical notions that are typically quite complicated to explain, and certainly for patients who are not mathematically trained, very difficult to understand and to interpret. Thank you very much for your attention.